My name's Sarah. I'm the Clinical Nurse Manager at Medicare Plus, and I'm going to speak to you now for about 40 minutes on moisture-associated skin damage in clinical practice. So we're going to talk about moisture-associated skin damage. This is skin damage that occurs when skin is exposed to excessive moisture, usually over a prolonged period of time. There's three main areas that are the sources of the moisture. So we've got incontinence, which we're mostly going to deal with today. We've also got wound exudate, which you're probably very familiar with. And we've also got perspiration as well. So with some patients, you can get excessive perspiration, maybe if they're pyrexial or for several other reasons, but particularly in the skin folds. So when we're talking about underarms, under breasts, under aprons, groins, all those sorts of areas, again, can be very vulnerable to skin damage from excessive moisture. So the signs of moisture-associated skin damage, I'm sure you're familiar again with some of these. So we're going to see signs of erythema and excoriation of the skin. You might be familiar with this picture of maceration here, which is quite an extreme example, but that's obviously when the skin becomes very overhydrated. It turns white and soggy. And again, that's when the skin can become particularly vulnerable to damage. It can be very painful for patients. It can cause itching and scratching as well, so you may start to see signs of the patient scratching the area, particularly if it's excoriated. And obviously any breakage in the skin, which is our body's natural protection against influx of microorganisms, is going to leave us at risk of secondary infection. So these are all the signs that we need to be thinking about and watching out for when we've got patients that we know are being exposed to moisture. So what happens to the skin when this moisture is exposed to it? So basically, when skin becomes overhydrated, it starts to lose its natural protective barrier function. It becomes much more permeable to irritants, so the skin becomes at much higher risk of breakdown and infection. One of the natural barrier protection provided by the skin is due to its naturally acidic pH. So our skin normally sits at around about 4.5 to 5.5 in pH. And it is this acidity that gives it protection against microorganisms particularly, because bacteria tend not to favour an acidic environment. So it's really important that we do maintain what we call this acid mantle of the skin. When the skin is exposed to, particularly from incontinence to urine and to faeces, if it has an impact particularly on this acidity of the skin, so this acid mantle becomes damaged. The urine contains urea, which can be converted into ammonia, and we know that ammonia is a very alkaline chemical, and particularly when it's combined with corrosive fecal enzymes. So when the skin is exposed to these sort of products, that acid mantle becomes damaged, the skin acidity is raised, and this leaves us again very vulnerable to secondary infection because it alters the normal skin flora and also more susceptible to damage. We also know that when the skin is wet and overhydrated, if we then expose that skin to forces such as shear and friction, it's much more likely to cause damage. Especially as well in terms of epidermal skin stripping. So if hydrated skin is exposed maybe to repeated use of adhesive dressings or adhesive devices such as stoma pouches, it's much more likely that that skin will become damaged from that skin stripping associated with the adhesives if it's also being exposed to moisture and starting to have damaging effects on the surface of the skin. It can cause debilitating pain and distress, as we've already mentioned. This can have a big impact on patients' quality of life. So it is something that we do really need to be mindful of when we're sort of assessing and planning care for the patient. It's also a major risk factor in the development of pressure ulcers. Now we know that moisture damage and pressure ulcers are very distinct. They have distinct causes, distinct treatments, but the research does show that when the skin particularly again is overhydrated, it's very vulnerable and at risk of damage, that if it's then exposed to pressure forces as well, this is much more likely to result in a pressure injury. So although they're very different They do sit alongside each other in terms of risk for the patient. So it's something to be mindful of. What we do need to consider, though, is that we're getting the diagnosis right. So even though we know that the risk becomes increased for pressure injury when the skin is exposed to moisture, we do need to be able to tell the difference and what the primary cause of any lesion is on the skin. This can be for several reasons. Obviously, the most important one is that if we don't diagnose what the original problem is properly, then we can't plan that treatment accordingly. This is much more likely to see a deterioration in the patient's skin condition, which obviously impacts on many different things. It can also affect our prevalence figures. As we all know, pressure injuries particularly are very sort of a high focus at the moment across all healthcare systems. But what happens if we diagnose something as a pressure injury when it's actually a moisture lesion is what we're going to see is those prevalence and incidence figures, which we're all very aware of within our working environment. We see those maybe going up, but they're not really reflecting the reality of what is happening in clinical practice because it's not actually a pressure injury that we're recording. So it's really important that we do get it right. This also can have financial implications, and again, we're in very much a time whereby we're trying to promote cost savings and sort of cost effectiveness as much as possible. We'd also need to check what your local protocols are in terms of recording moisture damage as well as pressure injuries. It used to be that it was only pressure injuries that needed to be recorded as a clinical incident, but I think now as tissue viability particularly is becoming much more aware of that link between pressure and moisture, they may also start asking you to record episodes of moisture damage as well. So you just need to go back and check what your local policies say. So there's 5 main ways in which we can tell the difference between moisture and pressure. The first one, particularly familiar, I would suppose, with people who are used to sort of assessing for pressure injuries, to look at the location. So we know that most pressure damage will occur over a bony prominence. With moisture damage, you're much more likely to see it occurring on the softer tissue. It can occur over a bony prominence, but like we say, it's much more likely to be more widespread into the softer tissue as well. You may see this sort of linear picture of redness which will extend down into the natal cleft. That's usually very indicative of moisture damage as opposed to pressure. So we are looking for that sign, particular sign of redness extending down in the linear fashion. In terms of the shape and the edges, with pressure ulcers, you're going to see a defined wound edge. So it may not necessarily be round, but it's much more likely to be regular in shape. With a moisture lesion, you're going to have a much more diffuse and widespread, sort of scattered picture of skin damage. So you might start to see a sort of rash-like appearance on the skin. The skin will become excoriated and red. What you may also see as well is something which we call a kissing lesion. I don't know if you're familiar with this. I always think about it when I was in school, and you'd have a piece of paper and you'd paint one side, maybe with a butterfly, and you'd fold the paper over and you'd open it back out and you'd see this symmetrical picture on the paper. And the similar sort of thing will happen with a kissing lesion. They most often occur sort of in that natal cleft area or in some kind of skin fold, and you'll see that symmetrical picture of skin damage on the opposing skin surfaces. This is very indicative of moisture damage because the research has shown that when that picture appears, we know that at least one side of that damage is due to moisture. So if we see that presentation, we have to be thinking about moisture as a cause, or at least running alongside pressure in that instance. In terms of colour, what's the first thing we're going to see if a patient presents with redness on the skin? Don't be frightened. What are we looking for? What are we looking to exclude? I can hear blanching. Absolutely, yeah. So any patient who presents with redness to the skin, the first thing we need to think about is excluding pressure as a source of that redness. So it's always going to be react to red, press the pink, all these sort of things need to be coming through our mind. So we're looking at is that area of skin blanching or not. Obviously, if it's non-blanching, this is a sign that there is damage to those underlying small blood vessels. This will be caused by pressure. If the area is blanching, and we see that sort of capillary refill happening quite quickly, this is indicative that this redness could be due to moisture. So we're always looking to exclude pressure as a primary cause. Obviously, with moisture damage as well, you will maybe see those signs of maceration. So any white tissue, white soggy sort of tissue, is obviously going to give an indication that moisture is the main cause. In terms of depth, we know that pressure ulcers can extend from intact skin right way down to bone. With moisture damage, they're usually very superficial only. So you're not going to see extensive depth in our moisture lesions. If we do see any slight depth occurring, it's usually due to a secondary infection of the skin. So again, just something to start thinking about, is there any infection going on here as well that may be complicating matters? And finally, necrosis. We know that we can get that dead eschar type of tissue in pressure ulcers. You won't find necrotic tissue within a moisture lesion. So again, it's something to exclude. So I want you to all come to work with me now, okay? So please do answer the questions. Have a good look at this skin. And based on what we've just discussed, what do you think is going on here primarily? Moisture, yeah, perfect. Any particular reason why? Incontinence, yeah, so we're sort of seeing that area which would be sort of covered by an incontinence pad. It's also that widespread sort of diffuse picture that we're seeing there that's very indicative of moisture damage. Pressure. So what's the main sort of factor that we could see there? Wound edge, yeah, so very defined wound edge. So we can see there's some redness extending down from the lesion itself. It may be there's a bit of exudate leakage going on there, so you know we may need to start thinking about, do we need to protect that peri-wound skin as well? But primarily, yes, the cause of that is pressure. Moisture. So what have we got going on here? Mirroring, so we've got that kissing lesion. So this is a really good example of a kissing lesion. So yeah, this is going to be primarily due to moisture. Well, we know at least one of those areas of skin damage is due to moisture. We still need to be doing our pressure risk assessments. We still need to be ruling out pressure as a cause of the damage, but moisture will be playing a part here. Pressure and moisture? Yeah. So this is what we call a combination lesion. So we've definitely got that pressure ulcer there, defined wound edge. We have got that extending redness around the edge. But particularly here, what you can see is when I was talking about that linear redness, which is extending down into the natal cleft. That's definitely a sign of moisture damage going on here. So it could be related to the wound, it could be related to perspiration, it could be related to incontinence. So again, we're going to go back, we're going to look at our patient, we're going to assess them properly and take into account everything that might be causing this skin damage. So how do we manage moisture damage? Ultimately, it comes down to good skin care. And I think maybe we all think that we're good at skin care and this should be easy for us. But I think perhaps we're not as good as being consistent about our approach to it and very structured. Maybe we take skincare as something that's just a due course for us as nurses, but it is something that we do need to give thought and consideration to. So obviously the good starting point for any skincare is to inspect the patient's skin. So we're going to be regularly looking at the patient from head to toe. We're going to be checking those skin folds. We're going to be checking those odd areas that pressure damage can occur, so the backs of the head, the ears, everywhere that we can possibly visualize, we're going to be looking at that patient's skin. If that patient is known to be at high risk of moisture damage, or has existing moisture damage, we should be attempting to check that patient's skin every single day, because what we want to do is obviously prevent any damage from occurring rather than trying to treat it once it already has. Another good point to sort of try again prevent moisture damage is to manage the source of the moisture in the first place. So I've put managing incontinence here because that's primarily what we're focusing on today. But this could be sort of, again, looking at wound exudate. Are we using the most appropriate wound dressing? Are we protecting the peri-wound skin? But ultimately, if we're managing incontinence, are we using the correct absorbency of pads? Are we using any specialist services that we may need to get involved to our continence teams, bowel and bladder services? Are we making sure that that patient is getting the best care that they possibly can? We know that we can't always, particularly within our ageing population, we can't correct the incontinence, but sometimes they can give some really useful advice. So any way that we can minimise exposure to moisture is obviously going to help with prevention. And then when it comes down to actual care of the skin, we're going to be looking at cleansing the skin, making sure that if the skin is intact, and especially with elderly patients, we know that the skin can become very dry and very fragile. So making sure that we're always trying to maintain skin integrity, making sure that it's hydrated and supple as much as possible. And then in terms of exposure to moisture or incontinence, we're going to be looking at protecting the skin. So cleansing of the skin, again, may be something that we don't often give enough consideration to. We know that particularly with incontinence, if the patient is incontinent, there's usually an increased need to cleanse the skin, and this cleansing in itself can cause damage. And that's due to several reasons. So again, they've looked into sort of what we use to cleanse the skin, and what they're finding is that there's going to be a big move away from using soap and water. And this is mainly because of the alkaline nature of the soaps particularly. So again, we're going back to preservation of that acid mantle. So we want to maintain the skin's natural barrier protection, which is through its acidity. And if we're using alkaline substances to cleanse the skin, then obviously we're disrupting that acid mantle, and we're then leaving the skin at risk of breakdown. So it is really important that we do start to think about what we're cleansing skin with, particularly if the patient is at high risk of damage, or if the patient again has got existing skin damage from moisture. There is research to show that if we do cleanse the skin with soap and water, we disrupt that acidic pH. It can take greater than 24 hours for that skin's pH to recover. So if we imagine that just even if we're just washing our patients on a daily basis with normal sort of personal care, we're never really allowing that skin's pH to recover its natural acidity. So just something to bear in mind. Cleansing with a neutral pH, non-soap, non-rinse cleanser is advised, again, particularly with patients with incontinence-associated dermatitis and any kind of moisture damage. It's also important to remember not to rub the skin. Again, going back, if the skin is already overhydrated, we expose it to friction through rubbing, then we can again cause damage to that skin. So patting or air drying wherever possible. So if we know that the patient is being exposed to moisture, we're now going to look at how we can protect that skin from that moisture. And we're going to mainly be doing this through the use of skin barrier protectants. And these are products that put a waterproof layer onto the skin to repel that moisture, to try to reduce the exposure to any irritants and irritation, and also to try and minimize exposure of the skin to any friction as well. They're there to help maintain skin integrity and reduce the risk of pressure damage by preventing that overhydration of the skin. We seem to be coming across a perception in some areas, because we go around doing a lot of training and education, obviously, into the skin barrier products, that these products can relieve pressure. You know, if we pop our patients all over with this magic cream, that we're somehow going to sort of minimize pressure. I'm sure we all understand that the only way to relieve pressure or to prevent pressure damage is to relieve pressure, to remove the source of the pressure. So while these products can put a barrier onto the skin, which can sort of help to minimize friction, they won't in themselves relieve pressure injuries. They can be used to prevent skin stripping. So if we're using them underneath adhesive dressings, or if we're using them on patients with stomas, again, they can help to prevent that skin stripping occurring, which can again cause damage, especially if the skin is already sort of being exposed to irritants, maybe from stoma effluent or from incontinence. Again, there's a move away from these what we call traditional skin protectant products. So these sort of zinc oxide-based products or products with a high petrolatum base, and moving on to products that have mainly silicone sort of based property to them. So there's, again, several reasons for this. The main one is that these sort of more traditional products, and this is a very extreme example that we can see here. I'd like to think that this doesn't happen very often, but what we're seeing here is basically misuse of the product. So it's being applied too thickly. It then becomes very, very difficult to remove. It's sticky and tacky. And then it starts to build up layers on the skin. You can't see through it, so you can't visualize what's happening to the skin underneath it. And then we have to then try and remove it, and this usually involves quite vigorous cleansing and rubbing, so we're exposing that damaged skin to friction, and again potentially perpetuating the damage rather than relieving it. They're also important as well, particularly continence services are particularly keen on this. They have been shown to block incontinence pads. So what happens is that these products will transfer from the skin onto the incontinence pad. And if you imagine that the incontinence pad itself is sort of made up of very small pores, and it blocks these pores. So we can reduce the absorbency of the incontinence pad. Obviously, we're using those to try and wick away that moisture. It's really important that we minimize exposure to moisture. So if those pads aren't working as effectively as they possibly can be, then obviously we're not going to be getting the best outcomes that we can. So why do we need to do this? Again, the evidence that has looked into it suggests that if we just put into place a structured skincare regime, so regular skin inspection, making sure we're taking away the source of the moisture, and proper cleansing, hydration and protection of the skin, we can achieve lots of good outcomes. So as you would expect, we would reduce erythema to the skin, we help maintain that normal skin pH. This in turn reduces the incidence of incontinence-associated dermatitis, and it can also, again, reduce the incidence of stage 1 and 2 pressure ulcers. So it's really important that we are mindful of how we are looking after our patient's skin. Unfortunately, going back to sort of are we good at skincare? There's not an awful lot of research into this, but the research that has been done suggests that while there may be strategies in place within our sort of working environments, we're probably not very good at sort of implementing them very well, or not at all in some cases. This can also be due to confusion over product choice as well. I'm sure we know that within wound care and skin care, there's so many products available to us, that particularly if you're not sort of experienced with what all these products do, it can become an absolute minefield to try and choose which is the best product to use at the best time. So it's sort of just becomes an exacerbation of the problem then, when we don't know how to use the products appropriately, and this can then lead to overuse and misuse of the product. This can have safety implications for the patient in terms of, are we managing their skincare properly? Because if the products are being misused or being applied incorrectly, then we might not again be doing the best in terms of their skincare. And this can then also have problems in terms of cost. We know that there's considerable spend on these types of products, skin protectants in the UK. So in the 2014, in the community alone, there was a £43 million spend on skin protectants. So it's a big area where we can focus on making sure that we're doing things as best as we possibly can, and helping then to make sure that we're minimising spend wherever possible. So what they did after sort of looking at this research was they went back and asked nurses and clinicians and carers, what is it that you need? What will help us to implement these skincare protocols better and make it easier for you? The key thing that came out was systematic staff education, so making sure that we're regularly going around and educating staff, which is great to see all you here today. And it's also about as well making sure that we're giving clinicians a set of products that are a smaller in number, so you're reducing that choice, that confusion that can be provided with too much choice. And we're giving you products that are acceptable to you, that you like, you find simple and easy to use. And that's for any caregiver, from sort of non-qualified to sort of very senior specialist nurses. Again, they still need to be an acceptable range of products for you to use. And again, backed up by that education on how to use them properly. Clear guidance and labelling was another thing that came out, was so making sure that it's very easy and clear to see what the primary core purpose of the product is. So is it an emollient? Is it for barrier protection? And sometimes even using a scale whereby sort of like a sun protection factor that you get on your sun creams, it sort of gives you an indication of how much protection that barrier product will apply. And also, as with anything, a clearly defined pathway of care that can help sort of, again, any caregiver help to make a decision about what will be the best product to use at the best time. So, obviously I work for Medicare Plus, so we do a range of barrier products. And what we did as a consequence of looking at the problems that were becoming much more evident in terms of skin care and what clinicians were looking for in terms of how best to use the products and how best to get as good outcomes as they possibly could, we devised a treatment strategy which is called Total Barrier Protection. And this is all about preventing skin damage and also protecting, repairing and restoring skin integrity. And it's all about sort of making sure that things are as simple as possible. It's giving you a single range of products. They've all got clear guidance of when to use them and take into account sort of the type and severity of damage that you're seeing to your patient's skin. It's all about tailoring it to individual patient needs, but also managing the budgets as well. So trying to reduce that misuse or overuse of skin protectants where they're not indicated. So again, this is just a representation of total barrier protection. So again, it's all about preventing, protecting, repairing, restoring the skin. What is your primary treatment aim? What are you trying to achieve? Are you looking to prevent skin damage, whereby certain products may be more useful than others? But if you've got a picture sort of here where you're really needing to put a very tough barrier onto the skin to try and sort of prevent any exposure to that severe skin damage and allow that skin to restore its integrity, then you're going to be looking at using different products for that sort of level of skin damage than you are maybe for when you're trying to protect or prevent intact skin from breaking down. How to choose skin barrier protectants is all about assessing your patient, and it's all about looking at basically what type of moisture is the patient being exposed to. So if the patient is incontinent, you may require a different product than if maybe you're looking to treat peri-wound skin damage. And also then, what is the amount of moisture present? Is it sort of quite small so that we're looking to prevent skin damage, or are we seeing very excessive amounts of moisture? We're seeing the skin starting to really severely break down, and then we're going to again be looking at using a different product. So there's several tools out there that have been devised to sort of help us to grade the level of skin damage. So this is particularly looking at incontinence. So what they say is sort of a low level of skin damage would be when you've got probably just urinary incontinence, maybe occasional fecal incontinence, infrequent cleansing and pad changes, and the skin is mostly intact. You might see some very, very superficial breakages only, and you'll see sort of signs of erythema, but mostly intact skin. So you're looking here to sort of really prevent any deterioration in the skin condition. When you've got a patient maybe where you're adding in fecal incontinence as well, and you're having sort of more episodes of this, and you're requiring quite regular pad changes and cleansing, you're starting to see that skin breaking down. So you've got that erythema, but you're also starting to see that rash-like skin damage as well, the signs of dermatitis and irritation. But if less than 50% of that total area is actually damaged, then we're looking at a moderate picture. If we move up a scale then and we've got very high exposure to moisture, what we're usually seeing here is liquid stool is involved. So maybe when a patient's got chronic diarrhea, or maybe they're having an acute episode of sort of C. diff, or they've got a chronic continence problem, and we're seeing prolonged and frequent exposure to maybe liquid stool associated with urinary incontinence, then we're going to see that skin becoming at very high risk of breaking down. It can break down really, really quickly. So they're going to be frequently cleansed, they're going to be frequently changed, and we're going to see that over 50% of that skin area will start to break down. So in terms of how we choose our products, we've got three main types. So we've got our creams, our films, and then our sort of ointments, our skin barrier protectant ointments. So we look at each of these in turn. But it's always going back to grading that level of skin damage to determine what would be the best product to use, and also what area are we using it on. So to start off with, we've got skin barrier creams. These are for gentle barrier protection. They're mainly used on intact skin or very, very mild sort of superficial damage. So we're mainly going to be using them for prevention of moisture damage or when there's very low levels of exposure to moisture. They still provide quite a resilient waterproof layer onto the skin. They can also protect from epidermal skin stripping, so you can still stick adhesive products to them. They're non-sting, they don't contain any alcohol or any irritants. So we're mainly going to be using our skin barrier creams for prevention of incontinence-associated dermatitis, and we might also see them used peristomally as well. What we're not going to be using skin barrier creams for is when we've got very high levels of moisture, because they just sort of can't cope with that level of exposure. And we're also not going to be using them in areas where it's already very moist or very warm. So we're not going to be using them to treat those skin folds, and we're not going to be using them around peri-wound areas as well, where the skin is usually going to be quite macerated and excoriated. When we're looking to step up from our cream to our film, this is when we're looking for something that's going to give us a much longer lasting barrier protection, and it's when that skin damage is maybe sort of starting to deteriorate. So we're looking at that mild to moderate picture of skin damage. We'll start to step up to a skin barrier film. They're a bit more resilient, they're also very versatile, so you can use your films around wounds, you can use them in skin folds, and you can also use them on areas of incontinence or peristomally as well, where you're starting to see that skin beginning to break down and the skin is becoming more wet. Again, they won't stop adhesive products sticking, and they're non-sting, they don't contain any irritants or anything like that, and they're very, very quick drying as well. So our skin barrier films are our step-up treatment. If we do get a patient whereby we're seeing that severe picture of skin damage, so you know, that skin is really starting to break down, it's very, very fragile and sore and excoriated, and we're looking for a product that's going to provide the maximum amount of barrier protection, then that's when we're going to be looking at using our skin protectant ointments. So these are the ointments which you may be familiar with. They've got this very tacky consistency, and it's that makes them adhere to that very moist skin. So you're going to be smoothing them very gently over the areas of skin damage, but you're able to do that because that tackiness will allow it to adhere to the skin. You can also use them as well, maybe in more severe skin fold damage, particularly if you can see here. This is a very typical pinprick rash, which will be associated with a candida or fungal infection. So if you're looking for something whereby you need to apply your antifungal treatments, you could apply those to the skin, give them some time to absorb, because they do need to be going into the skin, and then you can apply your skin barrier protectant over the top. That will then provide that waterproof barrier to protect further exposure to moisture. And finally, medical adhesive removers are something to think about as well. Like we said, we know when the skin is moist, it can become much higher risk of epidermal skin stripping. So it may be that these products can be quite useful at this time if we've got patients who have got using adhesive dressings, or particularly in stoma care, they're used quite frequently. Obviously, you're having patients with stomas who are having to frequently apply and remove adhesive devices. So it can be very, very useful just to gently remove those adhesive devices to prevent that skin stripping from occurring. In terms of application guides, if you take nothing away today, please take away that these products should not be over-applied. So it's coming back to making sure we're using the products appropriately, we're not misusing them or overusing them. So when we're looking at using skin barrier creams, we use something which we call pea to palm. So you're going to be able to use a pea-sized amount of cream will cover the area of a palm of your hand. So it's not a case of putting on as much as possible. You should always be able to visualize the skin through the cream. They're meant to be transparent so that you can continually assess. They're meant to be non-greasy. They'll be very quickly absorbed. So if the skin does feel greasy afterwards, we know that you've applied too much. So you can remove any excess with the tissue, but it's just to be mindful for next time that we do need to be applying less. So I always think about sort of, measuring out in palm areas, and then you can apply in pea-sized increments to the skin, and it makes sure that you're not over-applying. How to tell when you need to reapply. In some cases, you will be applying after every episode of incontinence, but what you should be looking for is looking for that sheen on the skin, which you will see when that barrier is still there. And also as well, looking for beading. And I always again think about this when I've just had my car waxed, and then you go out in the rain and you see those little droplets of rain which sort of run off the bonnet. So when you see that beading on the skin, again, that's an indication that barrier is still in place. So something to look for again. In terms of the film, like I said, they're more durable, so they're going to last for up to 72 hours. If you're using them on a patient whereby these patients are being cleansed frequently, it's not going to last as long as that. So just be mindful of, again, assessing your patient as a whole, assessing how incontinent they are, or how often their sort of bandages are being changed and dressings are being changed, and what's going to be the most appropriate product for that, and how often do I need to reapply it. Checking for that sheen and that beading. This is a picture that was given to me by a tissue viability nurse. It was a resident in a nursing home being treated for incontinence-associated dermatitis, quite nasty, with a barrier film. What she couldn't understand was that this patient's skin just kept on deteriorating despite the fact that they were supposedly being treated with the most appropriate product for the level of skin damage that they was presenting with. And when she got down to the bottom of it, this patient was being incontinent 5 times a day, and the barrier film was being applied 5 times a day. Now, like I said, these products are designed to only be applied every 24 to 72 hours. So what we've got here is a picture whereby products are being misused. They're building up on the skin because they're meant to naturally wear off. And what we're seeing is a picture of deteriorating skin damage. So I think the lesson here is maybe we can be a little bit blasé, it's only a cream, it's only a film. But they do still need to be used properly, and they do need still to be used as part of an assessed treatment of care so that we can achieve really good outcomes. It's not to do with the product, it's just to do with the way that we're using them. And finally, making sure that we do allow them to dry maybe before we reapply incontinence pads, or if they were using them in skin folds, making sure we hold the skin folds open until the product is dry before we release. They take no more than 30 seconds, so it's not that we have to stand there for very long. It's very, very quick to use. So again, I'm going to put you to work. So first of all, going back to that table that we saw, thinking about the area of the skin damage and also what the level of skin damage is. What do we think this picture of skin damage is? Mild, moderate or severe? Severe? Anyone from moderate? No, you're all going for severe. That's generally the case. I think people see blood and it's just automatic that you think severe. And this is nasty. You can see the area is edematous. It's extending down into the groin. So we are seeing quite a nasty picture of incontinence-associated dermatitis here. When you clean the skin up and you look at how much is actually damaged, then you could argue a case here that there's actually more of a moderate picture of skin damage. So again, you're going to be assessing your patient as a whole. You're going to be looking at what their skin condition is like at any one time. Is it getting better? Is it getting worse? So that you're continually assessing if you're using the right kind of product. I think the key as well is that these products are very much a step up and a step down. So if you've got a patient who has got severe skin damage, who has warranted the use of a protectant ointment, that doesn't mean that that patient will always need to be on that ointment. When that skin starts to recover, you can then start to step back down maybe to a film and then to a cream should the skin integrity become restored. So again, it's being mindful of what we're seeing at any one time. So which skin barrier product would you use here? Anyone for a cream? Film? Ointment? Film or ointment? I'd probably start with a film, again, because I'd probably go with moderate, but I don't think it would be wrong, again, if you were to assess a severe, if you know that that patient's skin is deteriorating, you know that they're being very frequently incontinent and they're going to need that really durable barrier. So level of skin damage here. Severe, yeah. So this is definitely severe. So again, we're going back, is that skin less than 50% or more than 50% broken? We've got complete loss of epithelium here. So we do know that this is a very severe picture of skin damage. This patient is probably going to be in a considerable amount of discomfort. So which barrier product are we going to be looking at? Ointment, yeah, definitely. If you can imagine trying to apply just a normal cream to something which is this wet and this damaged, it's just going to slip slide all over the place. It's not actually going to stay on the skin at all, so you're not going to get a meaningful barrier. With the protectant ointments, because they've got that tackiness, this is what they're designed for, is to adhere to this very damaged and moist skin. Sorry if you can't see this picture very well. Mild? Yeah, so the skin is actually really quite dry and fragile, so it's quite an elderly picture of what happens to elderly skin. You know, the skin becomes very dehydrated, but there is signs of erythema, and the skin is starting to develop some sort of signs of breaking down. So we've got a mild picture here, but again, we do need to be thinking about applying protection to the skin to stop it deteriorating. So the best product for use here? Cream, perfect, because it's got a moisturising element to it as well, so it's going to help with that dry skin, but it's also going to put that barrier on to protect from further breakdown. Level of skin damage here. Yeah, I think you're right. You have got some breakage, but they're quite small areas. So you, again, depending on the picture that the patient is presenting with, will help you to sort of assess what the level of skin damage is here. I'd probably go with moderate looking at that chart, but again, it's assessing individually. What would you use to protect the skin? Film. Film would be a really good choice here. So that's excellent. So finally, in conclusion, moisture-associated skin damage is really important. It can cause us significant clinical problems that we need to sort of be mindful of, and also on the effect that it can have on our patients as well. And it's looking at implementing strategies that can simplify the choice of skincare products available to us, make sure we're not using expensive products when they're not warranted, or misusing products by sort of applying them incorrectly, and just assessing our patient, what is their level of skin damage, what is the level of moisture they're being exposed to, and how can we sort of use our strategy to help us to consistently implement a standardized regime that's going to protect that patient's skin, and that's going to maximize patient outcomes, but also have an impact on sort of the financial implications that we're all becoming much more aware of.